Bismillahirrahmanirrahim. Assalamu alaikum. Today I'm going to talk about a very important topic, that is the interpretation of blood CP. And you can diagnose a variety of diseases, and you can say what is going on with this patient, what is wrong with this patient by looking just at the blood CP. The specificity of a blood CP is very high, but the sensitivity is low. What does that mean? It means if there is abnormality in the blood CP, specifically the patient is having the problem, dig out the problem. But if the blood CP is normal, the sensitivity is low. It means patient may or may not have the problems. So it depends upon the history, the clinical examination, and other investigation. So how do you check the validity of the blood CP? That this blood CP is done correctly by machine. So you take the ratio of the hemoglobin to hematocrit. If that is 1 to 3, this is right. How? Multiply the hemoglobin by 3. If the answer becomes equal to hematocrit, it's right. For example, say hemoglobin is 15 and you multiply 15 by 3, that is 45. The expected hematocrit is 45 and the hematocrit given is 45. So if they coincide, hemoglobin, the normal ratio is that 1 to 3, and we have to see whether the ratio is maintained or not. If that ratio is not maintained in the blood CP, repeat the blood CP before moving on to other parameters. Next thing is hemoglobin is normal, hematocrit is normal, the MCV is high or low. What is the problem? And we have seen a lot of cases, we are doing extra investigation which was not supposed to be done. So if this is that vial in which you are going to take the blood for blood CP, if you do not take the blood up to the mark, what will happen? You have taken less blood, and the EDTA or the anticoagulant that was in the blood CP vial, that draws the water from the RBC that was supposed to be diluted up to this mark. So if that water from the RBC, what happens? The RBC shrinks. When the RBC shrink, that give you smaller MCV. Now if you take more blood than that point, what will happen? The water enter into the RBC and that give you high MCV. So if the HB is normal, hematocrit is normal, but MCV is high or low, repeat the blood smear, repeat the peripheral smear, or repeat the blood CP. Next thing is, how can you diagnose the alpha thalassemia or iron deficiency anemia from the blood CP? Well, the answer to this is the Mentzer index. This will not be the final diagnosis, and this will not be revealed to the patient. A lot of times there are errors in the machine that is doing the blood CP. So before breaking the news of thalassemia, you have to confirm with the iron studies and the serum ferritin and the genetic studies and hemoglobin electrophoresis. But when will you suspect this? You apply the Mentzer index. The Mentzer index is, you divide MCV by RBC. If that is more than 13, this is iron deficiency anemia. If that is less than 13, this is alpha thalassemia. Because in majority of cases there is confusion. You are giving iron to the patient, but there is no response. The hemoglobin is not improving, and the anemia is microcytic hypochromic anemia. So that is the answer. Apply the Mentzer index, and if that is less than 13, this is thalassemia. Why less than 13 in thalassemia, more than 13 iron deficiency anemia? In iron deficiency anemia, your RBC are not producing. If your RBC are not producing, so the MCV by RBC, of course the MCV is down and the RBC is also down, but the decrease in RBC is more as compared to the MCV. So if you divide a bigger number by a smaller number, it will give you a bigger value. In thalassemia, the RBC is producing in a rapid rate. RBC is producing in a rapid rate. So in thalassemia, you are having MCV is decreased, but the RBC is high. So when you divide a smaller number by a bigger number, that will give you a smaller value, that is less than 13. So that is the concept behind that. Now what is the difference between blood CP and peripheral smear? Blood CP is done by a machine. You just give the sample, the machine takes the sample, and you get the result. Peripheral smear is the process of looking into the blood by a hematologist. The hematologist, they prepare the slides, and then they look under the microscope to look for any abnormality in the blood. So smear is more superior than blood CP. Smear is more superior than the blood CP. If you suspect some problems in the blood CP, go for peripheral smear. Now coming toward the main bulk of the lecture, that is, if the patient is having low HB, low hemoglobin, what is the next step? Look at the MCV. The MCV is low, normal, or high. If the MCV is low, what will you suspect? Iron deficiency anemia, thalassemia on the top. If the MCV is normal, what will you suspect? Anemia of chronic disease and hemolytic anemias. And if the MCV is high, what will you suspect? Megaloblastic anemia. Low HB, how would you proceed in a blood CP? Look at the MCV. If the MCV is low, normal, or high, we are having differentials. If the MCV is low, what is the most common cause of low MCV? Iron deficiency anemia. So you do iron studies. Serum ferritin is low, total iron binding capacity is high, and transferrin saturation is low. This is iron deficiency anemia. Find out the cause, treat the cause, and replace the iron. If the iron studies are normal, what is the best next step to do? Hemoglobin electrophoresis. The second most common cause of low MCV is thalassemia. The second most common cause of microcytic hypochromic anemia is thalassemia. If the hemoglobin electrophoresis is normal, what is the best next step in case of low MCV? Bone marrow. Exclude sideroblastic anemia. And if the sideroblastic anemia is excluded from the bone marrow, what is diagnosis? That is anemia of chronic disease. Find out the chronic disease. Anemia of chronic disease can present with the low MCV and normal MCV, but mostly it presents with the normal MCV. But if you have excluded all other causes from the low MCV, including the lead poisoning can also cause the low MCV. So if all the causes are excluded, then it is anemia of chronic disease. Find out the chronic disease. Now if the MCV is normal, what are your differential? Anemia of chronic disease, acute blood loss, hemolytic anemia, CKD, and aplastic anemia. In CKD and aplastic anemia, the size of RBC, that is normal. Well, in some cases, in aplastic anemia, the RBC size may become high. In some books it is mentioned. So it can present with megaloblastic anemia as well. The aplastic anemia, the macrocytic anemia, it can present with the macrocytic anemia, but most common it is normal size. If the MCV is high, the megaloblastic anemia, hypothyroidism, liver disease, and the drugs, these are the main causes. That is called the macrocytic anemia. How would you differentiate the megaloblastic from other causes? Hypersegmented neutrophil that can be seen on peripheral smear. Now coming towards the platelets in the blood CP, if the platelet is low or high. If it is high, then the upper limit is 10 lakh. If there is more than 4,50,000 or 4 lakh to 10 lakh, this is reactive. Reactive means there is inflammation or infection. The patient is having rheumatoid arthritis. The patient is having SLE. The patient is having worms infestation. You can expect the reactive increase in platelets. But if it is more than 10 lakh, think about myeloproliferative disorder. More than 10 lakh, think about myeloproliferative disorders. Now if the platelet count is low, what is the best next step? Is it true thrombocytopenia or pseudo thrombocytopenia? The pseudo thrombocytopenia means sometimes the platelet become sticky and they adhere with one another. So what the machine do, the machine in which you do blood CP, they take this as a WBC. So the machine can give you a high WBC and a low platelet. Suspect pseudothrombocytopenia in all those cases in which the WBC is raised and the platelet is low. The machine that is used for the blood CP, what it does, it cannot differentiate between the platelet and the blood CP. So between the platelet and WBC. So it gives the clumped platelet as WBC. So how can you differentiate between the two? If there is a thrombocytopenia, you must go for peripheral smear. The peripheral smear can tell you whether it is true or pseudo thrombocytopenia. If there is clumping, pseudo. If there is no clumping, true. What is the best next step if there is true thrombocytopenia? Whether there is decreased production of platelet or increased destruction of platelet. How can you differentiate between the two? You go for IPF. You go for IPF, that is immature platelet fraction, that is given in the blood CP. Most of the machines do not have this facility, but if you request them, they can do it for you. The IPF, that is the immature platelet fraction, that is just like a retic count of the RBC. A retic count of RBC. If the retic count is high, it means RBC production is normal. If the immature platelet fraction is normal, or high, that means production is normal. But if it is low, it means the production is abnormal. So what will you do if there is increased destruction, if there is decreased production? Now if there is decreased production, what will you do? Go for bone marrow. What is the problem over there? Go for bone marrow. What is the problem over there? But if there is increased destruction, you can think of ITP, you can think of splenomegaly, you can think of hypersplenism, you can think of PNH, paroxysmal nocturnal hemoglobinuria. But in that there may be pancytopenia, but they can give you true thrombocytopenia. So if the IPF is high, it means production is normal. No need of doing bone marrow as far as thrombocytopenia is concerned. But if the IPF is low, production is decreased, and go for bone marrow to exclude other organic causes. And if all the causes are excluded, bone marrow is normal. What is the cause? ITP. In most of the cases, it is the ITP. So in ITP, what will be the problem? That is, destruction is the problem. The antibody mediated destruction of the platelet is the problem. So in ITP, IPF will be high. So if you suspect ITP, you go for simple investigation, that is IPF, immature platelet fraction. If that is high, it means production is normal. So there is a high suspicion of ITP. If the IPF is low, it means the production from the bone marrow is abnormal. So the ITP, you can easily exclude the ITP by looking at the IPF. So coming toward the WBC, if the WBC count is low or high. If the WBC count is high, look the individual values: neutrophil, lymphocyte, and eosinophil. If there is predominant neutrophilic, think about acute stress, think about bacterial infection, community acquired pneumonia, UTI, abscess, think about the DKA, think about other acute stress. If there is lymphocytic, think about the viral infection and the steroids. Steroids increases lymphocyte and decreases the neutrophil. If it is eosinophilic, think about parasites and the drugs. The drug reaction can increase the eosinophil, the parasite can increase the eosinophil, and you can exclude also the myeloproliferative disorders if it is truly high. And if the basophil is high, think about the myeloproliferative disorder. So if there is a low WBC count, we have to look for the absolute neutrophil count. If there is less than 1000, so there is a increased chance of infection. But if there is less than 500, then it is severe neutropenia, and we have to look for the bugs. Even the normal flora, the normal nasal, oral, skin flora can cause infection if the neutrophil count is very low. So the bacterial infection on the top, the fungal infection so WBC count is low, we have to calculate the absolute neutrophil count. If that is less than 1000 and less than 500, on the top we are having bacterial infection, then fungal infection, and even the normal flora can cause severe infection and sepsis and even death. How can we calculate the ANC, that is absolute neutrophil count? Well, you take the percentage of what? The percentage that is given in the blood CP. In the blood CP they are given NL, and the percentage is given over there, 30%, 60%. so you put that percent in the formula, divide that by 100 and multiply by WBC from where? In the blood CP, that is also given in the blood CP. So if that is less than 1000, the person is at risk of severe infection and sepsis. So you have to cover all the three things: gram positive, gram negative, anaerobic infection and fungal infection. So if the ANC is low and the patient is in sepsis, you have to cover all these before the data of the blood culture is available. So with this I stop my lecture over here, and regarding pancytopenia I will make another video. Well, there is an algorithm for pancytopenia. Well, this was for isolated thrombocytopenia or thrombocytosis, leukopenia, leukocytosis, and anemia. Thank you for watching.